Hello, Sophie.
Hello.
Hi. Just waiting for a few others to gather. That's all right.
Okay. Yeah, that's fine. Thank you.
So
oh, hi. I can see the name down at the bottom. I wasn't quite sure who it was there.
Excellent. We've got a few more coming on board.
Hello.
Hello there. How are we doing? So we're expecting one or two more, I think. I'm Mike Grocott. Welcome, everyone. I'm just going to run through the list of posters and make sure we've got at least getting close to everybody we're expecting. So starting off, and sorry, the posters don't necessarily have your first name, so excuse me for, so Dr. Popovich. Are you there? Introduction of telemedicine assessments for preoperative oncology patients. I think that's Dr. Popovich just arrived. It will take a moment or two to get started, but okay, I'll skip through the next couple. Dr. Mathoulin.
Yep, here.
CPET, great, thank you. Dr. McCarthy.
Yeah, yeah.
Excellent, thank you. Dr. Carly Webb.
Yeah, I'm here.
Fantastic. Selby Johnson, Dr. Selby Johnson. Might be someone else from the group. Post-operative complications associated with differing neuromuscular blockade reversal. Okay, we'll come back to that one. Dr. Kerstin Campsall. Okay, and Dr. Roshan Verghese.
Yeah, that's me.
Hi, and I'll come back to the beginning. I think Dr. Popovich, who I think was logging in when I started.
Yes, I'm here.
Fantastic. Okay, so from the sounds of it, we may have a couple of people join us during the call, so please forgive any unscheduled interruptions. We've got a few posters to get through. So what we typically try and do is about 5 minutes per poster, and ideally a short, punchy presentation and then some questions. I will jump in and ask some questions, but I also really encourage you to ask each other questions and to treat this as a constructive opportunity to constructively challenge other people's data. Bear in mind, everybody gets a go, so that's a good stimulus, always a good stimulus for good behaviour. Thank you very much for sending your abstracts in to EBPOM Chicago. So I'm going to disappear now and get onto screen share so that we're all looking at the same thing, hopefully. And I will ask you to confirm in a moment that that is the case. Share screen. And hopefully you can see something that says abstract, EBPOM abstract poster forum, Thursday, 10th September.
Yes.
Yeah, that's correct.
Right, and it's filling the whole screen. I think most of the presentations are from the UK, so forgive us using British summertime, which is relevant to most of us, but may not be to everyone. We really appreciate you having submitted posters. This is only our second endeavour at doing this type of poster presentation, so an online conversation using Zoom. So while we're doing it, have a think about any things that you think we could improve. We're very happy to take criticism, any suggestions as to how we might make this a little bit better. You may already know, you may not know. So the three finalists have been selected already, and they will be doing an oral presentation on the main EBPOM Chicago program tomorrow, Friday 11th. So please join us then, and hopefully you managed to sign in free to the whole conference, and you've got an opportunity to dip in and out of some of the program and enjoy what we have going on over the next 3 days. Is anybody not from the UK on the call? Where are you from? Sorry.
I'm from the United States, Texas.
Texas, fantastic. Thank you for joining us. So excuse me if I'm slightly parochial for my British colleagues that say I'm actually not in Chicago. I'm sitting in Melton Mowbray because that was where we could get a studio space to do our bit of the virtual end of the Chicago study. So apologies to our friend in Texas, but Melton Mowbray is famous in the United Kingdom for pork pies. It's not famous anywhere else in the world, I'm quite sure, but just to give some context. We've got another meeting coming up shortly, another virtual meeting, because certainly in the UK at the moment, we're very much effectively locked down. So we've got our Irish meeting, which will be virtual, and then in the new year, our Las Vegas meeting, and then next summer, the main EBPOM London meeting. So please do join us for any or all of those. I hope it's reasonably clear what the format is. I hope you enjoy it. Please don't feel this is a threatening environment. It shouldn't be at all. It's supposed to be constructive and a learning environment. And before we kick off, does anybody have any questions? All reasonably clear. Okay, so I'm going to get my timer going. The first presentation is Dr. Popovich. I think is it Shannon Popovich?
Yes, sir, it is.
Yeah, fantastic. When you're ready, let me know and I will press the start button, and we look forward to your presentation.
I'm ready.
Great, thank you very much.
My name is Shannon Popovich. I'm one of the anesthesiologists at MD Anderson Cancer Center in Houston, Texas. And what we've worked on, I am the medical director of our Perioperative Evaluation and Management Center. We perform assessments for all oncology patients who are going to receive anesthesia for any surgery or diagnostic procedure here at MD Anderson. We do assess patients via in-clinic or some via telephone visits. And our center has had an exponential amount of growth with the increase in the number of anesthetizing locations. So we decided to pilot a program where we introduced telemedicine anesthesia assessments for our patients. And it truly came at a remarkable time with the onset of COVID and the difficulty for our patients to actually travel to the hospital in advance of their surgical procedure. So we are just sharing our story on how we established telemedicine and how it's gone so far for our center. So we, of course, selected Zoom, which is a HIPAA compliant video platform that obviously everyone is aware of, and it is fully integrated into our electronic health record. So our patients are piloted through this program by one of our clinic nurses who call the patient the day before, ensure the patient has the adequate resources and is prepared to log in for their telemedicine anesthesia visit. The patients do log in through their MyChart portal, which is their access into their medical record and into MD Anderson. And they arrive for their virtual visit. They can arrive 30 minutes before. They log into the portal. They complete any necessary consents that are required for telemedicine visits, as well as a questionnaire if they haven't completed it already, with a review of their current medical status and any symptoms they might be having. Once they arrive to that visit, they are greeted by our anesthesiologist or one of our advanced practice nurses, and we perform the entire visit as if they are right in front of us, with the exception of course, a detailed physical exam of the heart and lungs. So with this process, we wanted to assess any clinic volume variations that introducing telemedicine would allow. We wanted to find out the percentage of successfully completed telemedicine visits, and we wanted to look at our post-implementation case cancellation rate. By allowing our patients who are scheduled for these relatively straightforward procedures to have their telehealth visit instead of coming into the clinic, we wanted to, of course, start our telemedicine program, improve our oncology patients' access to the anesthesia provider, as well as their experience and patient satisfaction. So we are currently at week 18 right now, but after 15 weeks of our telemedicine visits, we did have in-clinic volume reduction from 6% at the onset in May to 15% in August. So this offload of patients who have normally been seen in clinic has allowed us the ability to, number one, ensure adequate social distancing in this time of COVID, but also for us to spend more time for the patients who are actually being seen in clinic as we prepare them for their surgery. Our post-implementation case cancellation rate for patients assessed via video has stayed at 0, which is a metric that we're very happy with. Our normal case cancellation rate, same-day case cancellation rate, is about 2.25%. And we have actually reduced a patient's physical journey through the hospital and their time spent in waiting rooms as they prepare for their anesthetic. So implementing telemedicine into our process of patient evaluation was the logical next step into accommodating this growth in patient population. It has been a benefit for the patient and the institution with great patient satisfaction. And our realized value for telemedicine as part of our anesthesia assessment, of course, has been increased quality of the assessment and decreased cost per patient.
Great, thank you very much indeed. I mean, just for clarity, was this something you were way down the path with before COVID, or was it something that was really catalyzed by COVID?
We were working on it in the year before the COVID hit, and we were of course had numerous roadblocks from an institutional standpoint, as they wanted to make sure that it rolled out, I guess, as slowly as possible, unfortunately, when we are dealing with bureaucracy. But COVID, of course, catalyzed that, and they wanted to allow us this ability to right away. So we were able to get started much sooner.
And one additional question, if I may, is it good for everyone, or are there some patients who you identify where this may be a little less satisfactory than a face-to-face interaction?
It's not good for everyone, no. We started off with very straightforward procedures, and we have a triage process whereby, based on a patient's questionnaire and their medical history, they are deemed to either be a higher risk, where they need to be seen in person, or a lower risk. So because the only physical exam we are able to see with the telemedicine is our airway exam, which is crucial for anesthesia, we really were gearing this towards patients who were relatively stable, or who we had perhaps even seen, in the past 6 months. So it is for a more straightforward population of patients.
Great, thank you very much. And sorry we don't have more time to discuss that, but we're going to move on to the next presentation, which is Dr. Mathoulin.
Hi.
Hi. When you're ready, let you go.
Are you ready?
Yep.
Wonderful. So I'm Dr. Sophie Mathoulin. I'm a senior anaesthetic registrar in Plymouth Hospital in Devon. And we conducted a survey in association with some of my colleagues, Andrew Biffin, Aaron James, Stuart Cleland, Gavin Werrett, looking at what the CPET practices, services were going on during the COVID-19 pandemic across the UK. So England, Scotland, Ireland, and Wales. Obviously during the pandemic, as we are still in it, but I'm talking more about the early days, kind of March, April time, there was obviously a significant amount of concern about bringing patients who are potentially vulnerable into a clinical environment where they may have increased risk of virus transmission. And also for those conducting the tests, that there's an increased risk of transmission to them when they are doing something that's an aerosol generating procedure, essentially. And at the time, some guidance was issued by the Poet Society, which, if we're all English by and large, we may well know, but the Preoperative Exercise Testing and Training Society. And essentially their guidance outlined that routine tests should not be continuing. the test should only be done if they it's going to change the patient's management, and the surgery is going to be done imminently. Staff should wear full PPE. Patients should be swabbed for COVID-19 beforehand, and they shouldn't be brought into hospital unnecessarily. So ideally, tying it in with other visits. And there was also some guidance released by CPET International, which sort of followed the same sort of guidance essentially. And POETS then released and updated that guidance in June, which followed the same lines, but with a few more caveats, specifically that's a risk benefit, and that the patient should be informed about the potential risks of coming into hospital and having the test done, with the option of then potentially declining the test if they don't wish to do so. So what I did was identify the perioperative leads as listed by the Centre of Perioperative Care in the UK, and each of those was sent a link with to an electronic survey. There was a total of 131 centres that we contacted, and we sent weekly reminders to try and increase the response rate over a period of approximately 4 weeks or so. So we had a total of 37 respondents and a response rate of 28%, which is amazing, but some of those centres don't have CPET services, of which we weren't completely sure of the numbers of who had CPET services and who didn't. So that may have contributed to our response rate. Out of the ones that did respond, 59% had either restarted or planned to restart in the near future. And 11% of those had stated that they didn't have a CPET service at their hospital. So that gave us some information. In those that had restarted, there was approximately 60% of reduction in the number of tests that were being done each week from pre-COVID to current times. And then we looked at what other assessments of functional status were being used. And the most popular, I'm sorry, the graph is quite small on the poster, but is the Darcy score, which is the Duke Activity Status Index. And then the 6-minute walk was the most popular after that. Many centres weren't doing any other assessments, or they were estimating metabolic equivalence based on patient reports. And things like grip and tug, shuttle, and or combination of others were also being used. We were then looking at the time weighted between each CPET, of which I didn't mention previously, but the POETS guidance in June outlined there should be a sort of waiting time of 6 cycles, I think it was, between each tests of air clearance within the room where it's being conducted. And so of those that responded to the question, the majority were waiting over 60 minutes. Some were waiting shorter, but that obviously would depend on their room size. And then we asked a question about level of PPE used. And again, the POETS guidance suggested that the patient should be, although they would be swabbed 24 to 48 hours ideally before the CPET testing, that they should be assumed to be an unknown with regards to COVID, and so full PPE should then be used. And you can see the spread, and so that full PPE would include gloves, apron, FFP3 mask, goggles or visor. And as you can see, there's quite a spread of what level of PPE is being used in those centres that are conducting tests at the moment. And with regards to the number of centres that were doing swab testing prior to the CPET, just over half were doing so, but obviously there's a large proportion that actually aren't swabbing as of yet. And spirometry is being used in quite a lot of centres, but many centres weren't using it at the moment because of concerns about aerosol generating and increasing risk. And whether or not the centres had to change their setup of their rooms to enable service to continue. Often that was removing furniture or having to go to a larger room or move rooms because there was a sort of outpatient waiting area, for example, alongside, and that was about 76% had needed to do that. So in conclusion, we feel that the surveys provided an important snapshot of what's going on in the UK with regards to cardiopulmonary exercise services during the pandemic. It's at a time when there's some guidance, but obviously very limited, and everyone's trying to interpret different information coming from different areas. And as we've said, the majority of services have actually got really up and starting from what we are aware of. And there's a suggestion that PPE is being used, but perhaps at different varying amounts to what has been advised. And that the swabbing of the patients before the CPET is also slightly more variable. And that the methods used to assess functional status as an alternative, again, is quite variable as to what people are using. There's no standardized alternative method at the moment. So thank you very much.
Thank you. Thank you very much indeed. So, I mean, given that we've got a clearly ongoing and sustained problem, I would encourage you to keep going with this. We're short of time for questions. My only question is, have you looked at comparing the response with the local rates of infection? Because there have been hospitals who've barely seen COVID in the UK, and there have been others that have been relatively overwhelmed, and that may be what drives, the variation you've observed.
Yeah, we tried on one of the questions, we tried to find out which region the hospital was in, but the response, the answers to those questions were quite variable. So we didn't have, and unfortunately, when it was completed, it was anonymized, and so we can't link up the people. So that's one thing that would be useful to consider in the future, is trying to link up the respondents to the answers that were given.
Brilliant. Thank you very much indeed. The next presentation, Dr. McCarthy, Tobias MacCarthy.
Yeah.
Brilliant. When you're ready. Thank you.
Hello, I'm Joe McCarthy, one of the medical students at the University of Cambridge. And I'd like to say thank you very much for having me, and also thank you to Tara Hughes, Paul Traynor, Fama Alagasami and Robert O'Neill at the Oesophagogastric Centre at Addenbrooke's Hospital. This project looked at how we could enhance post-operative recovery in patients undergoing surgical resection for esophagogastric malignancies, particularly with a focus on intravenous iron therapy for perioperative anemia. So preoperative anemia is associated with numerous poor post-operative outcomes, including an increased length of stay at hospital, increased morbidity and mortality, and numerous other factors such as increased blood transfusion requirements. Preoperative anemia in particular is easy to detect and easy to correct due to the normal delay between diagnosis and elective and the day of surgery. Patients with esophagogastric malignancy are highly predisposed towards iron deficiency anemia, and this is due to chronic blood loss within the GI tract, and also they are required to undergo a period of preoperative chemotherapy, which often causes a further drop within the hemoglobin levels. So in this project, we aim to determine the prevalence of anemia within this patient group, and also the impact of a defined anemia management pathway on the perioperative hemoglobin concentrations. This pathway focused on encouraging the use of intravenous iron therapy and treatment for any anemic patients, particularly in the post-operative period. So we performed a retrospective review of 400 patients who underwent esophagogastric cancer resection, and we noted the hemoglobin at the point of diagnosis, before the operation, during the post-operative period, and also at discharge and follow-up. And we matched this to any iron therapy given at any point. We defined anemia using the WHO criterion of less than 130 milligrams per litre hemoglobin for men and less than 120 milligrams per litre hemoglobin for women. And what we found was that 38% of patients were anemic according to the WHO criterion on the day of surgery. In particular, esophagectomy patients with esophageal malignancies demonstrated a greater post-operative decline in their hemoglobin compared to patients undergoing gastrectomy. And this is significant because it shows there's sort of differences in heterogeneity within upper GI malignancies, and that certain tumour sites are more predisposed to developing anemia post-operatively. We showed, or we identified, that the proportion of anemic patients receiving post-operative iron therapy was increased following the intervention, and inpatient intravenous iron was more effective than oral or no iron treatment in improving the hemoglobin status of these patients when assessed during follow-up. So the conclusion would be that over a third of patients with esophagogastric malignancies are anemic at diagnosis and the day of surgery, preoperatively. Inpatient post-operative intravenous iron was associated with a significantly faster improvement in hemoglobin in anemic patients when assessed at discharge. And this should form a component of the post-operative pathway for these patients. And this may be particularly relevant to those undergoing esophagectomy who are predisposed to a drop in their hemoglobin following the operation. Future studies should look to focus on the impact that intravenous iron can have in these patients on exercise tolerance and quality of life, and perhaps also on whether or not interventions could be performed preoperatively, which is more difficult given the tertiary nature of the centre and the way referrals are received from secondary sites. Thank you.
Great, thank you very much indeed. So one question, do you know, I can't see who was and wasn't transfused. So in terms of the hemoglobins later in the patient journey, do you know how much the contribution of transfusion is as opposed to the iron?
Yeah, so we did look at the blood transfusions, and for the purposes of the anemic patients, that we excluded any patients who received extensive blood transfusions, so 3 or more units, because they were sort of more, that was more related to the sort of intraoperative process rather than a tendency towards a decrease in hemoglobin. And we found that transfusions post-operatively didn't actually change between the pre and post-intervention groups. And we mainly looked at those who were given iron therapy just at the point of discharge, because patients tended to be given transfusions within the first 24 hours following their operation, probably more likely reflecting it being due to blood loss than the sort of more chronic process.
Great. I mean, you may or may not realise, but this is deeply topical right now. I don't know if the PREVENT study was published in the Lancet a few days ago.
Yeah.
Which appears, I was just chatting to the author this morning, and on the face of it says that this doesn't work at all, but which seems to fly in the experience of a lot of people who set up anemia clinics. So I think there's going to be a lot of hot debate in the next few months about where we go with preoperative anemia management. So thank you very much indeed for your presentation. Thank you. The next presentation, if I can get the slides to move forward. There we go. Is Dr. Carly Webb.
Hello. You ready for me to go?
Whenever you're ready, yeah.
Hello, I'm Carly Webb. I'm an anaesthetic clinical fellow at the University Hospitals Bristol. We are a tertiary cancer centre, and we already have some facility for prehabilitation of our patients, but currently it's targeted at high-risk patients only. And we're looking at building a business case to secure funding for expanding this service for all patients who are undergoing major cancer surgery who are either achieving less than 5 METs or who are failing to achieve the Chief Medical Officer recommended target for activity levels. So this would involve quite an expansion of our service. Currently, our high-risk patients are identified in the surgical clinic, and through their clinical nurse specialists are able to access kind of DVD resources and information about increasing their activity levels, and then have telephone follow-up. But we'd like to expand that and aim for one-to-one physio assessment and personalised exercise intervention. So we looked at a 2-month period in our preoperative assessment clinic, which is all run by consultant anaesthetists. And we got a snapshot of our regional patient population, looking at their fitness levels, as well as things like frailty, smoking status, diabetic control, as well as kind of significant psychological issues that could benefit from intervention prior to their operations. So looking at this 2-month snapshot, we had 193 patients who were going forward for major cancer surgery. This is, quite similar to what is probably known nationally, but we were felt that we had quite a high proportion of unfit patients, with 51% of patients not meeting Chief Medical Officer targets for physical activity, and 73% reporting not achieving over 5 METs. So looking at other things also, 31% of our patients have a BMI over 30, and around 6% reported significant psychological distress related to probably over and above the kind of normal psychological distress from a cancer diagnosis, who would benefit from particular intervention. So annually, this means that at least half of our patient population would benefit from prehabilitation prior to their operation. And we've broken this down into patients by specialty. And this figure number 1 just shows the patients that are Chief Medical Officer unfit by specialty. And as you can see, for example, our thoracic patients have the highest number of patients who would gain from further prehabilitation, but within the gynae population and the upper GI population, there's a higher proportion of patients who would benefit. So in conclusion, we think we have a really a lot of gain from physiotherapy input prior to these operations for our patients. And we believe that offering one-to-one physio assessment would give great benefit. The plan at the moment is to offer this as early in the patient journey as possible, and we have buy-in from the surgical teams and even the physicians to refer unfit patients to physiotherapy at the point of high suspicion of a cancer diagnosis in the respiratory clinic, or at the point of upper GI scope or surgical clinic. So we think that there's scope for improving patient experience, as well as increasing our survival and decreasing our length of stay. Thank you.
Great, thank you very much indeed. I'm actually surprised how many of your patients are CMO active. When I lecture to anaesthetists, certainly in the UK, have a reputation of being fairly fit, active people with the lycra-clad cyclists. I'm lucky if I get 20% of people to put their hands up and say they achieve what the 150 minutes of moderate or 75 minutes of higher intensity exercise. So maybe the Bristol patient is a more active patient.
Maybe.
Have you put any thought into so the notion of sort of universal and targeted and specialised interventions that is highlighted in the Macmillan guidance about how you might use this information to refine your service in that way?
Yeah, so at the moment we do have some targeted prehabilitation in place, and the plan is for patients to have physiotherapy intervention. So the CNS is to assess patients for whether they're fit or unfit, and then they go straight to being assessed by the physiotherapist. And obviously in a COVID world, this is going to look this is going to look different depending on what's happening. And I know that the SafeFit trial is doing great things with remote prehabilitation for patients, and it might be that for a period of time it needs to look like that kind of intervention. But the plan will be for one-to-one physio assessment and then personalised exercise intervention, and also planning assessment for psychological distress and targeting different forms of intervention like that as well. But to start with, the first phase will be the physiotherapy intervention, and then adding in the psychological intervention. And we already have an anaemia service, which is going to be probably further discussed now, and and also already have input for nutritional issues and diabetic control already. So this is really to just enhance the service for all unfit patients rather than just high-risk patients.
Brilliant. Thank you very much indeed. The next presentation is Dr. Johnson, if you're there. Selby Johnson. You may be on mute if you're not there, although we didn't have this. This looks like a Duke presentation, and I didn't hear any other US voices. So we can come back to this if Dr. Johnson appears, but I'm going to skip on to the next presentation, which is Dr. Campsall. Are you there, Dr. Kerstin Campsall? You may be muted.
I'm unmuted. Can you hear me? Can you hear?
Okay. We'll come back to that. Next presentation after that is Dr. Roshan Verghese. I'm sure was here before.
Yeah, I'm here. I'm still here. I'm audible.
Thank you. Start when you're ready.
Yes. Hi, my name is Dr. Roshan. I'm one of the clinical fellows working at Leeds Teaching Hospitals. I'm unfortunately in the labor ward at the moment, so there might be a few midwives disturbing me. So please, I do apologize for them. The study we did was a study when I was in India probably a year ago, and the study was evaluation of ultrasound as a clinical tool for localization of the epidural space. And we are trying to compare it to the normal technique or the palpation technique that we do, also known as the external landmark technique. Epidural has been in place for a long, long time. I think it started in the early 20th century, so 1920s. We have obviously progressed quite a lot with higher success rates and lesser failures and complications. However, still the rate of failure is still quite high. For example, in labor, anesthesia, it can be as high as 1 in 8 or 1 in 20 women in case they're going for a section. And also rate of complications, for example, dural puncture is as high as 1 in 100. And you obviously have the nerve complications after that. So that is why we did a study to see whether ultrasound can actually help us, in decreasing the immediate complication, that is the dural puncture. We unfortunately didn't have a long-term follow-up with respect to the nerve damage, so I can't comment much on that. And whether it actually enhanced and improved the whole experience of having an epidural. So we all know that epidural injection, it depends upon two things. First is our knowledge of the anatomy of the back. And the other thing is that what we feel when we're putting the needle in the back. As we all know, there were studies that have conducted which said that whenever we predict the space in which we are going, it can be wrong in about 60 to 70% of the time. So we can predict it accurately in only 30 to 35% of the occasions. And also the tactile feedback that we get from the needle, there can be a false positive. That is, there might be a loss of resistance when there's actually not the space, or there can be a false negative as well. So epidural can hopefully help us with that. And also we deal with a lot of different population of people. So there can be people who have a high BMI, who had problems with the spine before, or who might have had difficult epidurals in the past. And especially in these patients, ultrasound can be beneficial. At least that's what the other report says. So we said they will try and do it at our center and see whether it's actually beneficial. So the study was conducted in a tertiary teaching hospital in which we took 60 adult patients, ASA 1 to 3, who were scheduled to receive lumbar epidural. I have not mentioned that, but this is only lumbar epidural anesthesia. And they were randomly allocated into two groups. So one of the group was in which the investigator did an ultrasound before the epidural was put in, and we sort of made a mark on the skin. So we used two views. We used the paramedian sagittal oblique view, and we used the transverse approach to guide us with the epidural needle placement. We could have used the midline approach or the median approach as well, but the problem was the image quality was not the best, and that's why we went on to the paramedian sagittal oblique view. What we are trying to do with the PSO view, as I've called it there, is we're just trying to locate the depth of the epidural space. And the exact point of location was determined by the transverse approach. So in the figure that is present, I'm sorry, the figure is too small for us to actually sort of differentiate the different structures. But the only thing that I can point out is that The most posterior hyperechoic structure was considered to be the ligamentum flavum, and hence that was predicted to be the depth of the epidural space. And then we can see sort of a hypoechoic space after that, and that's the spinal canal where the CSF is. So once we were able to localize the space with the help of the transverse approach, we basically made two markings on the skin, and that gave us the exact point of insertion of the needle. Then we did the epidural as normal, so using a 16 or 18 gauge 2-His needle, loss of resistance to saline. And the point at which we got the loss of resistance, that point was marked on the epidural needle so that we could compare the depth. So we had the ultrasound guided depth, which we got from the ESO view. And then we had the depth because of the marking on the needle. We compared those two markings and then saw whether we could actually correctly predict the depth or not. So we did a statistical analysis, and what we observed was that we had a good correlation in the depth. So as we can see that the depth which the epidural predicted was roughly quite similar to that which was actually obtained in all these 30 patients. And it said that the correlation was significant, so it was 0.96. However, the other thing that we were mainly interested in was the number of attempts in both the groups, which was obviously not less. There were a few reasons for this. First of all, the patients that we selected, they were not suspected to have difficult epidurals or anticipated difficult epidurals. So I think they were probably, most of them had a normal BMI. They did not have any spine deformities. And that is why if you see the number of attempts is quite similar. Also, all these epidurals were performed by a consultant anesthetist. Probably that helps to decrease the number of attempts because they're more proficient in the procedure. So what we concluded was that the usefulness of ultrasound for decreasing the number of attempts or for localization of the epidural space is limited. It does give you a good prediction of the depth, but it does require some practice before we can accurately predict the depth of the epidural space. There are a few variables in the study which we had conducted, but I have not mentioned it here. So we had taken into consideration the time taken for the ultrasound for the epidural and other variations, but I have not mentioned it because I think there's less space on the chart.
Great, thank you very much. We're kind of short of time for questions, but I guess the only thing, I'm not a regional anaesthetist, but although you didn't show a significant difference, it does look like there's something of a trend towards attempts. And as you already commented, they were relatively straightforward, non-obese patients. So as with all these things, we only come up with binary results from these types of studies, but it does look to me like there may be something in it. So
yes.
Thank you very much.
No worries, yes, appreciate it.
Thank you.
Okay.
Great. Now, have I missed anybody out? Because I'm conscious that we went over a couple of slides where people weren't there. Is there anybody who's on the call who hasn't had an opportunity to present?
Yes, can you hear me okay?
Hi, sorry, yes.
I'm sorry about my technical problems earlier. Do we have time for me to present still?
We do, of course, have time for you to present. Let me just, is this you? Yeah, I'm guessing you're not Dan.
I'm not Dan, no, I'm working at home. So I only actually work 2 days a week and I'm at home today. So I'm borrowing my husband's office, bless him.
Excellent. Well, welcome. Please, when you're ready, go ahead and present.
Thank you. Just give me 2 seconds.
Of course.
And I'll be sorted. So my name's Kerstin Campsall. I'm an occupational therapist and I work on the surgical emergency wards at the John Radcliffe. So the title of the project is Therapy-Led Delirium Management in an Emergency Surgical Unit. So we have 3 wards at the John Radcliffe under ESU. We have a kind of triage area with 12 beds, an additional 6 kind of casualty trolleys, a treatment room and a waiting area. And we take patients there directly from GPs, paramedics. We really work that unit as a mini ED to alleviate ED. We then have an 18-bedded ward on 6E and a 20-bedded ward on 6F. And as therapists, we cover all of those. So the main conditions that we're seeing are things like small bowel obstruction, diverticulitis, laparotomies, Hartmann's procedures, colectomies, pancreatitis, gallstones, all that type of malarkey. And obviously a number of our patients stay quite a while in ICU, and we know that therefore have a higher rate of delirium. We had started a kind of quality improvements project on one of the units on Ward 6F to try and work as a task force together on delirium, because we felt that we weren't managing our delirious patients very well. And we'd started to look at things like red trays for meal times and better signage and better orientation. And then unfortunately, COVID struck and our whole floor was turned into a COVID positive unit. So we had some surgical emergency cases, but also a number of COVID patients. And obviously during this time, the number of those patients experiencing delirium increased, and just really reflected that we weren't really measuring delirium within those patients. So our quality improvements team stopped because we were just busy dealing with the outbreak. But as therapists, we felt that we weren't managing these patients well, and it was taking a lot of nursing time. So we just did a very short study on Ward 6F. So for the first patient cohort, we took 4 weeks and we continued with our standard occupational therapy intervention. So that's initial interviews, functional assessments, sometimes a cognitive assessment such as the MOCA, and general discharge planning. And within all of our assessments, we try to orientate patients. So we would talk about why they're in the John Radcliffe, where they were, time of day, who we were, what had happened to them. But it wasn't standardized and it was quite ad hoc. But during this time, we recorded the date of admission to the ward, the length of patient stay, the date of onset for delirium, and we chose it to be documented by the doctors. We found that often on the nurse's handover, it might say delirium, or the doctors might record fluctuating cognition, but we didn't find many doctors who were really comfortable to actually note a diagnosis of delirium. So we also looked at discharge date and destination and whether their delirium had resolved prior to discharge. So within those first 4 weeks, we found that we had only categorized 15 diagnoses of delirium within 28 days. We then trained all the therapy staff with the tools that we were going to use to try and actually support the delirious patient. And we presented the project to the MDT, so they were aware of what we were doing. So for the following 4 weeks, we were planning to continue with our standard OT intervention, but alongside that, do some additional screening. So every patient who attended the unit, we used the 4AT on, and if they had a positive score, that's 4 or more, then we would look to continue with further treatment. And we chose the 4AT because we know that it performs well for patient sensitivity and for completion rates. We know that it's well recognised. We know that we can use it at first patient contact and also at other times when delirium is suspected. But we're also aware that it's not really designed for repeated daily monitoring of delirium. So if somebody scored positive, we wanted additional tools to try and help them on their journey. So we devised a checklist, which has a lot of similarities to RICOT, which is the Royal College of OT's checklists. So just, is the patient able to mobilise? Are they engaging in functional activities? Are there the right environmental cues around for them? Clocks, calendars, to help with their orientation? Is there good lighting in the room? Can they sleep at night? Do they have access to familiar objects? So we were trying to get family photos in, pictures sent using other technology so they could link with family and friends. Do they have their glasses and their hearing aids? Really simple things that help with orientation. Do they have the correct level of pain relief and adequate hydration and nutrition? Is the environment calm and are they comfortable? And do they have a good day and night cycle? Do they have any other unmet needs that we've just not really picked up on as an MDT? So constipation, temperature control, any other discomfort? When were their meds last reviewed? Or is any other potential unknown source of infection or neurological event that's occurred? So we did this checklist, and once we'd done that and felt that we'd covered everything we could, we then began with something called the orientation log, because we wanted something that could regularly help patients to become reorientated. So this isn't just about assessing orientation, but it's also about helping them to grow in their orientation. So it's a 10 scale assessment tool. It is a serial assessment of orientation, so you can see if somebody progresses or deteriorates, and it really measures place, time and situation. It can be used with anybody who's potentially disorientated, and the questions that are used within the tool are not specific to any particular disorder. But what we really liked about it, and you can see on the poster, is that it plots a graph day by day over time of how the patient's progressing. So it's quick and easy to see whether someone's deteriorated. So each of the subsections are scored from 0 to 3, 3 being a spontaneous and correct response, 2 meaning that an initial response is lacking, but with a logical cue, somebody is able to give the right answer. 1 is that they need a recognition cue, so multiple choice cue, or 0 is that they've really not managed to answer the questions at all. So we would conduct the OLOG with patients if they positively identified through the 4AT as having delirium, and we would do that on a daily basis. And one of the things that we wanted to do with this project was ensure that actually our therapy assistants could be doing this, so that we could cover a number of patients and we could do it at a regular time, and we could build in good rapport with the patients. So this is something that's quite easy to replicate and quite quick to do. Unfortunately, we identified 9 patients with delirium just 10 days during the treatment phase where we were doing the additional assessments. But the trust decided, or the hospital decided, that they needed to change our ward and relocate our patients. Some of them were discharged to nursing homes or community hospitals, and some were moved to the gynae wards just because of demand. So with the reconfiguration, our project was actually stopped. But compared to 15 patients identifying with the delirium in 28 days with the first patient cohort, we identified 9 within 10 days during our assessment phase. So it did give us a clear measure of delirium, and that we could actually enumerate that at point of discharge. We could say whether somebody had improved. We actually found that patients were responding well and improving by using the OLOG and our other tools. But obviously we can't interpret any of these results. It's not reliable, the sample's too small. And some of our results were skewed because some patients had long stays in ICU, and we know that affects cognition and delirium. We'd like to have another go at the project, and we are meeting again now that our wards are actually, but 6F is becoming 6F again, hopefully by the end of September. And with the reconfiguration, we hope to run the project again. Interestingly, the therapy assistants and the other therapy staff, I've been off since the 10th of July, have continued using the OLOG, the 4AT, and the delirium checklist on patients, and that's been a positive move forward for them. And really what this project identified is that actually we're not always very good at diagnosing delirium, especially with patients where it's quite mild. And by using the 4AT and a checklist and the OLOG, it did appear to improve clinical decision making in terms of discharge options and destinations. And we think that it does have the potential to reduce the time a patient experiences delirium, and therefore have an impact on length of stay and discharge options.
Thank you very much indeed. We're probably a little bit over time on that one, so I won't ask any questions. Can I just check that there's no one else who had technical difficulties or came in late that hasn't had a chance to present so far? It's always a little bit more challenging than face-to-face. Okay, great. So listen, I'd like to thank you all for your presentations. As I mentioned at the beginning, we would really appreciate any feedback on your experience of the process and how it might be improved. And I hope that you're able to join in on some of the rest of the EBPOM Chicago meeting tomorrow and over the weekend and the subsequent meetings that we have. So really appreciate the time that you all put into preparing your presentations and the very high quality presentations this afternoon. And thank you very much for joining us, and we hope to see you again. Thank you.
Thank you very much.
Thank you.
Thank you. Thank you.
Thanks a lot. Goodbye. You're good to go.